You know that feeling? When you're faced with something really complex, maybe a dense article or a research paper, and you just wish you had a way to instantly get what's really important.
Yeah, like a shortcut.
Exactly. To cut through all the noise and get straight to the core insights. Well, that's pretty much what we do here on the Deep Dive. Consider this your personal shortcut to, well, getting informed.
And today, we're taking that deep dive into a really fascinating, maybe even groundbreaking area, the role of oxygen treatment in multiple sclerosis, or MS.
That's right. We've got this paper titled simply Oxygen Treatment for Multiple Sclerosis Patients. And our mission, yours and ours, is to pull out the crucial bits of knowledge from this research.
To see what it tells us about the possibilities of using oxygen-based therapies for MS.
Definitely. Now, before we sort of plunge into the science, just think for a second. When you consider how MS is typically treated, what are some of the first things that, pop into your head?
It's a good question to start with, because to really grasp the potential impact of oxygen, we first need a solid understanding of multiple sclerosis itself.
Right.
And one of the first key insights from the paper is that while we call MS this chronic degenerative disease of the nervous system, the actual terms multiple and sclerosis, they describe what's seen pathologically.
So they're descriptions, not the root cause diagnosis itself.
Precisely. Multiple just means there's more than one area affected, and sclerosis refers to that hardening, that scarring reaction in those areas.
Okay, so it's not just one problem in one specific spot.
Exactly. And the criteria doctors use, they're quite specific for diagnosing MS. They need clinical evidence, proof of damage in more than one area of the central nervous system.
Okay.
And crucially, these damaged areas must have occurred at different points in time. Dissemination in time, they call it.
And how far apart in time?
Well, interestingly, the minimum gap they look for is only about a month, a lunar month, technically. But this spread, this dissemination, can happen over a really long time sometimes, the paper says, as long as 45 years.
Wow, 45 years.
Yeah. And what's also really important to remember is that while symptoms from an MS attack can sometimes resolve seemingly disappear on their own, often these episodes leave behind some lasting damage, particularly to the myelin sheath. That's the protective insulation around our nerve fibers.
And those are the white spots we often hear about on MRI scans, right? The WMHs or UBOs.
Exactly. Those bright areas on a T2 weighted MRI, those white matter hyperintensities or unidentified bright objects, they indicate damage. But, and this is a really crucial point the paper makes,
Okay.
standard MRI has a big limitation. It can't easily tell the difference between edema, that's swelling, which is potentially treatable, and actual sclerosis, the permanent scarring, which isn't really reversible.
Okay. That distinction seems pretty critical for treatment.
It really is. And here's where it gets even more interesting. Even when there is some sustained damage visible on the scan, a person's actual function might seem totally normal on a clinical examination.
So they feel fine, look fine to the doctor.
Sometimes, yes. But if you dig deeper with more sensitive tests, like evoked response studies, think of these as measuring how fast electrical signals travel along nerves.
Right.
They might still show underlying problems, like a definite slowing of those signals, even if, say, someone's vision seems to have fully recovered after an episode of optic neuritis.
So just because things look okay on the surface doesn't mean everything's completely back to normal underneath.
That's a very good way to put it. Historically, MS was actually called disseminated sclerosis. That name really emphasized those widespread, hardened plaques they found in the brain's white matter.
Right. Disseminated meaning spread out.
Exactly. And even with all our modern imaging, getting a definitive MS diagnosis can still be quite challenging. Sometimes it even requires examining tissue after death to rule out other conditions that might mimic MS.
Really? Post-mortem.
In some difficult cases, yes. The paper mentions the somewhat, unsettling reality that sometimes the diagnosis basically comes down to having no better explanation for the patient's symptoms. And another thing, while we often associate MS with the white matter, the wiring of the brain, it's important to know that lesions also commonly occur in the brain's outer layer, the cortex. And in the spinal cord, they affect both gray and white matter pretty much equally.
Okay, now let's touch on the theory that's been dominant for so long. The idea that MS is an autoimmune disease.
Yes, the autoimmunity theory for, over 50 years now? The main view has been that the body's immune system mistakenly attacks its own myelin,
Mm.
However, the paper highlights a really significant point here. Despite decades of research, scientists haven't actually pinned down a specific myelin-derived antigen.
The specific trigger molecule from myelin,
Exactly. The thing that would supposedly set off this autoimmune attack, it hasn't been identified. And this lack of a specific target raises a really important question.
which is
Could the immune changes we see in MS actually be a secondary response? Maybe an innate immune response kicking in after some initial damage, perhaps similar to what happens after a stroke.
that would be a pretty different way of looking at it.
It certainly would. It shifts the focus. The paper also emphasizes something else often overlooked. There's significant axonal loss in MS damage to the nerve fibers themselves.
Not just the insulation, the myelin.
Right. We're talking a minimum of 20% loss in the spinal cord and similar levels in brain lesions. And this damage to the axons themselves can help explain some of the cognitive changes people experience, things that might not always be obvious during a standard clinical exam.
Okay, so it's a complex picture.
Right.
Inflammation, myelin damage, axonal loss.
Right.
Where does the oxygen piece fit in?
This is where the paper introduces some really critical findings, particularly from a technique called magnetic resonance spectroscopy, MRS.
Okay, what's MRS?
Think of it as a way for the MRI scanner to look at the chemical composition of tissues, not just the structure. And what MRS has shown in acute active MS lesions is the presence of lactate.
Lactate. Isn't that linked to lack of oxygen?
Precisely. Lactate is a classic hallmark of hypoxia, a lack of sufficient oxygen getting to the tissues. And what's particularly interesting is that this localized oxygen shortage, this hypoxia, doesn't just seem to be a result of the damage. It appears to actively contribute to it. The paper explains how this focal hypoxia can trigger the body to recruit neutrophils, a type of immune cell. These neutrophils then release harmful substances, free radicals, which leads to more inflammation and more tissue damage.
So it's like a vicious cycle then.
Yeah.
Damage leads to low oxygen, which then causes more inflammation and damage.
That's a pretty good way to conceptualize it, yes. The MS attacks themselves involve this local breakdown of the blood-brain barrier, that protective layer around the blood vessels in the brain, and spinal cord, along with inflammation.
Okay.
Multiple imaging techniques have shown this, and what's even more striking, this disruption of the blood-brain barrier can actually happen before any symptoms even show up.
Wow, before you even feel anything.
Yes. And the paper brings up another interesting observation, often overlooked. Changes in the blood vessels of the retina at the back of the eye. It's called paraphlebitis.
Okay.
This indicates a problem with the blood-retinal barrier. Now, since the retina doesn't have any myelin, this observation provides pretty strong evidence suggesting that the primary issue in MS might indeed be these changes in the blood vessel barriers, like the blood-brain barrier, rather than an initial attack solely focused on myelin.
That's a really important connection. It shifts the focus, like you said.
It really does. The paper then mentions, how common chronic MS is in Western countries, maybe 100 to 150 cases per 100,000 people. But it also notes something quite surprising.
What's that?
Asymptomatic lesions. Those MS-like spots on an MRI that don't cause any noticeable symptoms, they're actually really common in the general population.
How common?
Up to 40% of people might have them on an MRI.
40%. That's huge. It makes you wonder why they cause problems in some people and not others.
Exactly. What triggers them to become clinically significant? And furthermore, the paper emphasizes that once that blood-brain barrier is damaged, subsequent attacks might not even involve the same initial disease mechanism.
How so?
Well, think about the hot bath test. A rise in body temperature can temporarily worsen MS symptoms. In some cases, it's even been linked to causing permanent disability. This highlights the vulnerability of a nervous system that's already compromised by that barrier damage.
It's more susceptible.
Yes. And what's also quite striking is the often poor correlation between how disabled a patient is clinically and the amount of damage found in their brain after death on autopsy.
So the scans don't always match the symptoms perfectly.
Not always.
Yeah.
But even very small lesions, if they're in critical areas like the optic nerves, the brainstem, or the spinal cord, can have a huge impact on function.
And that helps explain the really unpredictable nature of the disease. The different patterns like relapsing, remitting, chronic progressive, chronic stable MS.
Exactly. And the paper also offers a slightly more optimistic perspective, pointing out that contrary to the common perception of MS as inevitably leading to severe disability,
Yeah.
MRI evidence actually suggests only about 25% of patients eventually become wheelchair dependent.
Okay, that's important context. So if these issues with blood vessels, the barrier, and lack of oxygen seems central, this naturally leads us to this idea of microembolism, right?
Yes, exactly. The paper presents a pretty compelling argument for looking at a vascular mechanism. Specifically, microembolism, these tiny blockages in very small blood vessels, as a potential underlying common cause for the lesions.
And what's the theory behind that? Where would these blockages come from?
Well, the theory proposed is that it could result from the lungs failing to effectively filter out small debris circulating in the bloodstream, particularly fat globules.
Fats.
Yes, and these fat particles might then release toxic fatty acids when they get lodged somewhere. This could explain a classic observation about MS lesions. They tend to occur around veins. They're perivinous. This location is consistent with a microembolic mechanism where small particles bypass the lungs' filtering system, the pulmonary trap, and then get stuck in the delicate venules, the small veins of the brain and spinal cord.
That anatomical length, the perivinous location, is really suggestive.
It is. And neuropathologists have even observed that under the microscope, the late-stage lesions you see after an acute fat embolism, where fat particles definitely block blood vessels, look virtually indistinguishable from acute MS lesions.
Wow. Okay.
The paper also draws a fascinating parallel with decompression sickness.
The bends and divers.
Right. In decompression sickness, tiny gas bubbles form in the blood and can damage the blood-brain barrier. And guess what? They cause very similar pathological changes in the optic nerves, the brainstem, and the spinal cord, precisely the areas most commonly affected in MS.
That comparison is quite striking.
It really is. Then there's this term doctors use, clinically isolated syndrome, or CIS.
Right, for a first episode like optic neuritis.
Exactly, like optic neuritis or transverse myelitis. But even though it's called isolated, MRI scans often show that multiple areas of the nervous system are already affected, even at that first clinical event.
So clinically isolated, but not necessarily pathologically isolated.
Precisely. The term really just emphasizes that challenge in neurology. You need objective evidence of these events happening separated in time, that dissemination over time, for a definitive MS diagnosis. The paper even mentions a proposed alternative term, monosclerosis, for these CIS patients, but it hasn't really caught on.
Okay, so we've built this case. Potential links between oxygen deprivation, vascular issues like microemboli, barrier breakdown, and MS lesions. This brings us squarely to the core topic, the rationale for hyperbaric oxygen treatment. HBOT.
Exactly. Now we're getting to the why HBOT part. The paper starts by pointing out that historically those acute attacks, the ones we now often recognize as potentially the first sign of MS, weren't really treated as urgent emergencies. For something like an optic neuritis attack, the main treatment became high-dose intravenous steroids, like methylprednisolone. But even the studies supporting that needed patients to have had symptoms for several days first.
Wait.
To avoid mistaking a natural, spontaneous improvement, which can happen for a treatment effect. And this same kind of thinking, focusing on more established disease, influenced the early studies of HBOT for MSS. They often enrolled people with long-standing, chronic, stable disease, maybe diagnosed 10 years or more.
So the initial focus wasn't necessarily on intervening in those early acute attacks.
Not primarily, no. But our understanding of how oxygen actually works at a cellular level has advanced significantly since then. A huge breakthrough was the discovery of hypoxia-inducible factor transcription proteins, HIFs.
HIFs?
Yeah, think of them as master regulators inside cells that sense oxygen levels and switch genes on or off in response. They control the body's complex responses to low oxygen. And crucially, they provide a direct link between hypoxia, lack of oxygen, and inflammation.
Ah, so low oxygen can directly trigger inflammation pathways through these HIFs.
That's the connection, yes. It turns out the oxygen level within our cells acts as a really critical biological signal. And this brings us to the main logic behind using HBOT for MS.
Okay, lay it out for us.
In an active MS lesion, you have swelling edema. This swelling physically increases the distance that oxygen has to diffuse from the nearest tiny blood vessel, the capillary, to reach the nerve cells that need it.
Right, it's harder for the oxygen to get there.
Exactly. So by having someone breathe pure oxygen in a pressurized chamber during HBOT, you dramatically increase the amount of oxygen dissolved in the blood plasma, not just carried by red blood cells. This boosts the oxygen pressure gradient, the driving force pushing oxygen from the blood out into the tissues. It helps overcome that increased diffusion distance caused by the edema.
Makes sense. Get more oxygen closer to where it's needed.
Precisely. And the paper also reminds us that other things are oxygen dependent too, like the ability of cerebral blood vessels to properly regulate blood flow, and even the active transport of essential things like glucose across the blood-brain barrier.
So adequate oxygen is needed for the whole system around the nerves to work properly too.
That seems to be the case. Now, the paper does include a cautionary note from some diving experiments.
Oh.
In one instance, the high oxygen levels from hyperbaric exposure caused vasoconstriction narrowing of blood vessels, which led to temporary vision loss in someone who already had a history of optic neuritis. So it just highlights there's a balance.
Okay, note of caution.
Yes. But the main argument remains, since those initial clinically isolated attacks actually seem to involve multiple sites in the nervous system right from the start, targeting these acute inflammatory events where edema is likely significant, with HBOT seems like a very logical approach.
And does the paper give examples where HBOT is used for similar issues?
It does. It mentions successful use of HBOT in other conditions involving optic nerve damage and swelling, like ischemic optic neuritis linked to decompression sickness, and also optic nerve damage caused by radiation therapy, all situations where edema is a key factor.
Okay. And what about specific cases involving MS patients themselves?
Yes. The author shares an anecdote, a case report of an MS patient who had complete vision loss from an acute optic neuritis attack. After a course of HBOT, they apparently regained full vision.
Wow. Complete recovery.
According to the report, yes. There's also another case described involving someone who developed focal neurological signs and visual problems after a head trauma, where HBOT also seemed to lead to improvement. And more broadly, the paper cites evidence that HBOT can reduce overall brain swelling, global cerebral edema, and actually improve mortality rates in cases of severe head injury.
Okay, so evidence from related conditions.
Yeah.
But the really key thing would be evidence in MS itself, especially imaging evidence.
Absolutely. And the paper does present MRI evidence specifically from MS patients. It shows a reduction in edema, the swelling within the lesions after HBOT. Incredibly, some lesions even appeared to disappear on the scan after just a single hour of treatment.
An hour. That fast. That really suggests it's hitting the edema component, doesn't it?
It strongly suggests that resolving the edema is a key part of the improvement mechanism, yes. It's quite a striking finding. The paper explains that even though HBOT might slightly reduce overall blood flow due to that vasoconstriction effect, it massively increases the amount of oxygen carried dissolved in the plasma. So the net effect is significantly improved oxygen delivery to those hypoxic tissues. This helps them switch back to normal aerobic metabolism, making energy efficiently again.
Yeah.
They even provide some numbers. For example, at 2 atmospheres absolute pressure, breathing 100% oxygen, the oxygen tension in arterial blood might be around 1100 millimilli year, and even the venous blood leaving the tissue still has an oxygen tension around 70 millimilli Hg, which is much higher than normal arterial levels at sea level air.
So you're really flooding the tissue with available oxygen.
That's the idea. And remember, the HIF proteins. More oxygen at the cellular level in that hypoxic environment helps to reduce inflammation by downregulating that key protein, HIF-1. It interferes with its stability via another protein called von Hippel-Lando, or VHL.
So reducing the inflammation signal.
Yes, and there's potentially another repair mechanism the paper brings up.
What's that?
Stem cell release. Some studies have shown that HBOT can stimulate the release of stem cells from the bone marrow into the circulation. One study mentioned found an 8-fold increase in circulating stem cells after a course of HBOT given for complications of head and neck cancer treatment.
Stem cells. So HBOT might both reduce the damage and actively promote repair.
That's the really exciting possibility this research points towards. The paper reiterates that the critical factors seem to be getting enough oxygen available in the affected tissue and having that high plasma oxygen tension as the driving force for these beneficial effects. It then goes on to describe the progression of that blood-brain barrier disturbance. It starts with just increased water content, edema, the swelling. Then plasma proteins can leak out and they can damage the oligodendrocytes, the myelin-making cells, and the myelin itself. And in the most severe form, even red blood cells can leak out. That's called diapetesis. When that happens, they break down and release free iron, which is very toxic and can lead to tissue necrosis, actual tissue death.
A cascade of damage.
Yes. And interestingly, the paper points back to some early research way back in the 1970s on experimental allergic encephalomyelitis, or EAE.
That's the animal model of MS, right?
Exactly. And those early studies showed that HBOT had positive effects in EAE, which
Mm.
also involves a breakdown of the blood-brain barrier. In fact, in those animal studies, HBOT even seemed to have some immunosuppressive effects.
And how is EAE typically induced? Is that relevant?
It's very relevant to the microembolism theory, actually.
Mm.
EAE is often induced by injecting brain tissue mixed with something called Friend's adjuvant. This adjuvant contains mineral oils and bits of tubercle bacilli, the tuberculosis bacteria.
Oh.
The paper proposes that this injection process itself probably causes blood-brain barrier disruption via a microembolic mechanism just from injecting that oily substance. Then the inflammation from the body reacting to the tuberculin components could create local tissue hypoxia because the swelling limits oxygen flow right when the tissue is metabolically revved up by the inflammation.
So the EAE model itself might involve hypoxia.
It seems likely. And animal studies have directly shown that HBOT reduces spinal cord edema in the AE models, and they've even measured increased tissue oxygen levels with the treatment.
Okay.
Furthermore, other EAE studies, using different ways to induce inflammation, like injecting lipopolysaccharide or Salmonella abortus directly, found that giving the animals 80% oxygen at normal atmospheric pressure,
They're not even hyperbaric.
right, just higher oxygen concentration at normal pressure, that alone resolved the neurological disabilities and prevented demyelination. This provides even more support for the idea of using oxygen, maybe even just high-flow oxygen, early on in acute MS attacks.
Wow. This lab evidence, both the mechanisms and the animal models, certainly builds a strong case. So what about the actual clinical trials in humans? What do they show?
Right, the human evidence. The paper walks us through the history here. It starts with the very first report of HBOT being used for MS patients back in 1970.
Okay, that early.
Yes, that initial report showed some symptomatic improvement in some patients, but it was quite limited, small scale, no real long-term follow-up. Then in 1978, there was another report that specifically drew parallels between MS symptoms and decompression sickness symptoms, and it reported favorable results with HBOT.
Interesting comparison.
It is. And these early positive signals were independently confirmed over in the U.S. by Dr. Neubauer around the same time. He apparently noticed a patient's MS symptoms getting better while they were receiving HBOT for something else entirely, a bone infection called osteomyelitis.
Huh, serendipity.
Seems like it. Then there were beneficial reports coming out of Italy in the early 1980s as well.
But the really pivotal one people often point to, was the New York University study in 1983, right?
Yes, absolutely. The study by Fisher and colleagues at NYU Medical Center in '83, that's considered a landmark because it was the first randomized, placebo-controlled, double-blind trial. They were very careful to match the patients in the HBOT group and the placebo group based on disease severity, duration, all sorts of factors.
So it was rigorously designed. What did they find?
They found significant objective improvements in the group that got the real HBOT. That was 2 atmospheres pressure for 90 minutes, 5 days a week for 20 treatments.
Improvements in what?
In things like mobility, fatigue, balance, and notably bladder function compared to the group that got the placebo treatment, which was just air at a very slight pressure.
Okay.
Importantly, they also found that patients who had less severe MS to begin with tended to have a better response, and it lasted longer. And even a year later, with no more treatment in between, the group that had received HBOT had deteriorated less on average than the control group.
That sounds pretty significant.
It was. The researchers themselves concluded that further investigation was definitely warranted, especially looking at HBOT for acute attacks and also the long-term effects of maintenance treatment.
So that study kind of set a high standard, but also pointed out areas where we still needed more information, like long-term use.
Exactly. It laid a strong foundation, but it had limitations, you know?
Yeah.
It used one fixed pressure, a fixed number of sessions, and crucially, no follow-on or maintenance therapy. The paper also mentioned some potential issues in other trials,
Like what?
like variability in actually measuring the oxygen levels in the patient's blood, and the practical problem of masks sometimes leaking, which means you don't know exactly how much oxygen they were truly getting. And many subsequent trials, the paper notes, varied a lot in quality and often focused on patients with very long-standing, stable disabilities.
Which might be a harder group to show improvement in.
Potentially, yes, especially if the goal is to reverse damage rather than just manage symptoms or slow progression.
What about the studies from the UK around that time? from Newcastle and London.
Right. The Newcastle group, led by Barnes, initially published findings that seemed a bit dismissive of HBOT, but interestingly, in their later follow-up papers, they actually called for more research.
Why it's changed?
Because even in their data, they found statistically significant improvements in bladder function in the HBOT group at both 1 month and 6 months after treatment. And they also noted less worsening of cerebellar function, things like balance and coordination, at the 1-year mark in the HBOT group.
So even the initially skeptical groups found positive signals.
It appears so, yes. And then the second big UK study from Wiles and colleagues in London also specifically showed objective improvements in bladder function, even in patients who were quite severely affected by MS. And this was under properly controlled conditions.
Bladder function keeps coming up.
It does. It seems to be one of the areas where HBOT shows a consistent, measurable benefit across several studies.
And you mentioned earlier the Italian study suggested that continuing the treatment might be key for longer-lasting benefits.
Yes, exactly. 2 Italian studies provided good evidence for that. Oriani's group gave patients weekly HBOT sessions for a whole year after an initial course. They found appreciable differences in outcomes compared to controls, and even improvements in visual evoked responses, those nerve signal tests.
A full year of treatment.
Yes. And Pelota's group followed patients for a remarkable 8 years. They found a significantly lower relapse frequency in the group that received prolonged intermittent HBOT compared to patients who only got the initial 20 sessions.
8 years. That really points towards consistency being important.
It strongly suggests that, yes, it's not just a one-off fix. And actually, following those encouraging early results, particularly the New York study, something interesting happened in the UK.
What was that?
Patients themselves, through charity initiatives, basically established the MS National Therapy Centers. It became a whole network of centers specifically providing multi-place hyperbaric oxygen therapy chambers, where several people can be treated at once.
Wow, patients set them up.
Largely driven by patient demand and fundraising, yes. And the paper mentions Dr. George Schumacher, a respected figure from the International Federation of Multiple Sclerosis Societies. He pointed out how difficult traditional double-blind trials are in MS because the symptoms fluctuate so much naturally.
Right, the moving target problem.
Exactly. He suggested that maybe long-term longitudinal studies where patients act as their own controls over time might be more informative. And the key measure of success, he argued, should be whether the treatment arrests the downhill progression of the disease.
And what did he conclude based on that view?
His view, as reported in the paper, was that HBOT was the only treatment approach at that time which had shown persistent benefits in these kinds of long-term studies.
That's quite a statement. And these MS therapy centers in the UK must have gathered a huge amount of real-world data since then.
An enormous amount. The paper states that since 1982, they've treated over 25,000 patients and delivered more than 3 million individual HBOT sessions.
3 million.
Yes. And critically, they report doing so without any significant adverse safety incidents. This really puts them in a unique position to look at the long-term effects, outside of the constraints of a formal short-term clinical trial. They were deregulated in 2008, meaning they operate more like wellness centers now, but the data collected is vast.
So what did their long-term follow-up show?
A detailed analysis by Perrins and James looking at over 700 patients treated according to the center's specific protocols, often starting at lower pressures like 1.25 or 1.5 atmospheres, and only increasing if needed, found that around 70% experienced relief in 2 or more of their MS symptoms.
70%, that's substantial.
It is. And again, bladder improvements were consistently confirmed. They also found, like the Fisher study, that patients with less advanced disease tended to respond better initially. But interestingly, they found lower pressures were often effective, and perhaps most importantly,
Yes.
how someone responded right at the beginning didn't always predict their long-term outcome. This really suggests that sticking with the treatment, regular follow-on therapy, is crucial.
Okay.
And subsequent surveys they did, looking at patients after 2 to 4 years and then again at 6 to 8 years, indicated that those initial improvements were generally being maintained in patients who continued with regular follow-up HBOT.
Maintained over 6 to 8 years is impressive. Do they have data even longer term than that?
They do. A third survey looked at 447 patients who had been receiving treatment for 10 to 14 years.
10 to 14 years?
Yes. It showed that 23% of those long-term attendees were objectively rated as no worse than when they started treatment over a decade earlier, and 7% had actually improved.
Wow. After a decade with a progressive disease, staying stable or improving is huge.
It really is. Their analysis suggested that roughly 300 treatments over 10 or more years, which works out to about one session every couple of weeks, seemed necessary to significantly slow down progression in relapsing remitting MS. And getting over 500 treatments, maybe closer to weekly, appeared even more effective.
So frequency matters.
It seems to. Now, obviously, doing a double-blind study for 10 plus years is practically impossible because people just wouldn't stick to a placebo for that long. But comparing different treatment patterns within this large group strongly pointed towards the importance of regular, ongoing treatment at all time points.
Could you give an example of that comparison?
Yeah, they looked specifically at the change in disability scores, the Kurtzky DSS score over 10 plus years in relapsing remitting patients, based on how many follow-on treatments they'd had. There was a clear difference. Those with fewer than 300 treatments worsened significantly more than those who had over 500 treatments.
That's compelling evidence from real-world use.
It is. And they note that of the 1,384 patients who first started treatment over 17 years ago, 11% were still attending regularly.
Still going after 17 plus years.
Yes, and they looked closely at a group of 117 patients who had been attending regularly for between 5 and 17 years. For that group, their average disability score had increased by no more than 1 point on the Kurtzky scale during that entire period.
Which is remarkably slow progression for MS over such a long time.
Extremely slow for many patients. So the paper's conclusion, based on this extensive experience, is that the HBOT treatment, as administered by these UK MS therapy centers, is practical, it's safe, and it appears to be cost-effective when delivered in these community settings. The fact that 38% of that 10-14-year cohort were still attending regularly speaks volumes.
And side effects.
The main side effect reported is just occasional ear discomfort from the pressure changes, like you get on an airplane, which is usually manageable. They emphasize the lack of significant side effects over millions of treatments.
Cost.
They mention the cost per treatment is relatively low, surprisingly so, comparing it to something mundane like the cost of a haircut. And anecdotally, many patients continued treatment purely for symptom control, like managing urinary frequency, and some even plan their holidays around being able to access a center or have installed monoplace chambers, single-person chambers in their own homes.
That level of commitment really suggests they perceive a significant benefit.
It certainly does. It speaks volumes about the perceived value to the patients themselves over the long term.
Okay, so to try and bring all of this together from our deep dive, where do we stand?
Well, we've seen pretty compelling evidence, I think, suggesting that hypoxia, that lack of oxygen, plays a really significant role in the acute MS lesion. It's not just a bystander effect.
Right, it seems to actively contribute to the inflammation and damage.
Exactly. And the rationale for using oxygen treatment, particularly hyperbaric oxygen, to counteract that hypoxia and reduce the associated edema and inflammation seems biologically plausible and is supported by quite a bit of science, including animal models. And then, when we look at the human studies, especially the very long-term data gathered from the UK MS Therapy Centers network, it strongly indicates that regular, sustained HBOT can have a beneficial influence on the overall course of the disease.
Slowing progression, helping manage symptoms over years, even decades for some.
Yes, potentially. Particularly, it seems, if treatment is started earlier rather than later in the disease course, and crucially, if it's maintained consistently over time. The frequency of treatment seems linked to the degree of benefit in slowing progression.
So consistency and starting relatively early seem to be key takeaways.
Those are definitely key takeaways from this paper's analysis of the evidence, and it also touches on the potential social and economic advantages, having a relatively inexpensive, safe, long-term treatment available in the community that could improve quality of life and maybe reduce the need for more costly interventions later on.
This has certainly given us, and hopefully you listening, a lot to think about regarding oxygen and MS. It feels like a perspective that maybe doesn't get as much mainstream attention.
It perhaps doesn't compared to pharmaceutical approaches.
So for you, the listener, here's a final thought to chew on. Given these findings, this accumulation of evidence from basic science, animal models, controlled trials, and particularly that long-term real-world experience, what are the broader implications?
Yeah, how should this influence how we understand MS and how we approach its treatment?
Does this research suggest it might be time to perhaps reevaluate or further explore the potential role of oxygen therapies like HBOT in managing this really complex condition? It's definitely a question worth pondering, maybe discussing further.